Hi, I'm Lillian Medhus. This presentation will go over the very basics of coding, billing, and reimbursement. This is a complex topic, and it can be a difficult learning curve as a new midwife. If it's not part of the orientation at your first position, I recommend asking for a few hours with the practice billing specialist to go over the basics for your specific site. You may be wondering, why is this important? Maybe you're thinking, I didn't go into midwifery to make money, I just want to take care of people. While that's all true, currently in the US, we have a capitalist healthcare system, meaning it runs on dollars generated. If you work for a small private practice or start your own practice, understanding these topics means you get paid. If you work for a larger hospital group, if the midwifery service doesn't bring in revenue, there may be little motivation to continue the service. Either way, it's important for creating value in midwifery services and giving us a seat at the table. The first topic we will review is coding. Coding refers to a specific set of numbers and letters that refer to a diagnosis. The ICD is a database of the officially recognized codes that all providers must use. Every visit must have at least one associated code in order to be reimbursed by the patient's insurance. The more specific a code is, the more likely it is to be covered. Additionally, the more codes that are associated with a complex visit, the more likely you are to get paid for all of the time and services provided. For example, if you see a patient for anemia, you could use the anemia unspecified cause diagnosis, but it would be better to use the specific code if known. So if it's known to be due to iron deficiency, using the code iron deficiency is preferable. You'll likely be able to search for these codes in a database through your electronic health record. Think of the ICD code as the assessment in your SOAP note. Some examples of commonly used codes are listed on the slide. Pregnancy is routine antenatal care with a specifier for the number of pregnancies and the trimester. So Z30401 is supervision of normal first pregnancy in the first trimester. Z30402 is first pregnancy in the second trimester, and so on. Other normal pregnancies use Z348 with the trimester specifier. Well woman or annual visits without abnormal findings is Z01419. If there are abnormal findings, there's another code that's used in addition to a code for the finding. For example, abnormal vaginal discharge. There are many codes, and don't worry about memorizing them. Just understand the purpose and know where to look to get the right code for your visits. The pregnant patients you care for will be using the Global OB package for their care. This means that they are billed for one complete package of care, which includes their prenatal visits, birth, and routine postpartum care. It does not include evaluation of non-pregnancy related issues during OB visits, labs, ultrasounds, extra OB visits for high-risk pregnancies, for example, AMA, GDM. This is why it's very important that you attach all ICD codes to your visits, document the services you provide, and provide information on the amount of time spent on non-pregnancy related issues. This allows your biller to bill for additional services outside of the global package and demonstrates the true value of the care you are providing. If we don't document all of the work we are doing, including information provided to patients, we do a disservice to midwifery. Billing is another confusing topic, and there will likely be a person in your practice whose whole job is to do the billing of the visits. They should provide you with a handout or chart on the most commonly used CPT codes for the practice. Again, you do not need to memorize this, but simply understand what it is used for. There will also be tools available to use to decide what level of medical decision-making went into your visit so you can bill for the highest level of care. For example, a patient coming in for vaginitis is a lower level of medical decision-making than a patient coming in for a breast lump because the implications of the visit are higher for a breast lump. The basics are: make sure you document at the end of your note the time spent with the patient, document all of your differential diagnoses, and your specific plan of care. All of this will help your biller demonstrate the care that was provided. The 992 codes are what you will use most often for gynecologic visits, pregnancy, and postpartum. Other codes will be used for annual exams and procedures. Reimbursement refers to the amount of money that is reimbursed to the client after the midwife submits the bill. The practice will bill the insurance company a set amount based on the services provided and the time spent with the patient. However, the practice will not necessarily receive that amount back in reimbursement. Medicare, Medicaid, and private insurance companies each have a set amount that they will reimburse for any given service. So even if your practice bills for $100, if their cap is $75, you will receive back $75. Further, each company has a set physician pay scale, which is the highest amount that can be reimbursed. Medicare reimburses CNMs at 100% of the physician pay scale. This is great for equitable access to midwifery because it ensures more midwives will accept Medicare. When an insurance company reimburses CNMs at a lower rate, it can cause a CNM practice to lose money on those services. Additionally, the hospital practice may be less inclined to hire CNMs knowing that they won't make as much revenue for the company. However, Medicare is typically used only by the elderly or the disabled. Thus, most midwife clients are not on Medicare. Medicaid, however, depends on the state. Some states do reimburse at 100%, others do not. This makes it more difficult for some CNMs to provide care for patients on Medicaid. Finally, private insurance companies have contracts with each practice that submits claims to them. Thus, they may reimburse X clinic at 100% and Y clinic in the same city at 75%. This is an area for much needed advocacy for equitable reimbursement, which in turn increases access to midwifery care for vulnerable populations. In summary, the main points are: meet with the coder and biller at your first job. Document everything that you do. Chart the time spent with a patient, and then advocate for equitable CNM reimbursement at the local and national levels.